We talked maybe 5 weeks ago about the facet joint, and as I've thought more about this topic, it is so common to have facet joint problems, and we underappreciate the pathologies involved. So just to recap, the facet joints in the spine are synovial joints, much like other common joints in the body. And they are formed by the union of two vertebrae, and they're on the back side of the spine, whereas the discs are on the front. So each motion segment has one disc and two facet joints. We know that the ligaments that support all synovial joints are critically important. And as we go through the conversation, I want you to be thinking about some of the principles of ligament physiology and pathology, because it does seem to me like the underlying problem with bone spur formation and facet joint pathology is a ligament issue. We know that there's innervation to the joint, and our pain doctors especially take advantage of this in good procedures to treat painful facet joints by ablating the nerve that goes to the joint. And then we also know, in addition to the ligaments that surround the joint, we have muscle. And some patients will come in, and I think they probably do need to strengthen their core, and others have lower back pain and some kind of disc or ligament issue and really strong core. And so there's sort of different things that you look at when you evaluate a patient. Okay, so we're going to start off with this case, which I think illustrates some important principles. This was a young woman that they were headed on the wrong side of the freeway early on a Sunday morning and head-on collision. And she came in, she had a pretty bad head injury. And she also had this CT scan of her lumbar spine. So I know that some of you are very used to looking at scans, and others are looking at them occasionally, but I think it's good for all of us to just look at the scans and what do you see on her lumbar CT? Anybody want to comment on what they see? Okay, so are you pointing here?
Yeah, the other side, like the coronal.
On the coronal? I think there is a fracture through this is the transverse process, and there is a little bit of a fracture at the transverse process. That's really good. Anything else that you see? Scott?
I think L was a 2-3. Would be unstable because if you look at the posterior process, the gap between them versus the others below, so it might be a posterior longitudinal ligament injury.
Yeah. So if you look at the spacing between the spinous processes, there's a big gap here, slight angulation, and something going on right there. There's a little, I'm not exactly sure what that is. Maybe it's a little bit of blood, or Dr. Jackson would probably know, but there's some kind of issue at the back part of the disc at that L2-3 level. Okay. So normally, and we would probably take this patient to surgery around the time of the accident, but chose not to because she had this really bad head injury and had a bunch of other injuries. That when she came in, she was in the OR for several hours, and she had no pressing need to do surgery for this. One principle of ligament injuries is that they can tolerate an increasing amount of load if applied over the right amount of time, but a sudden onset of load can cause them to tear. Now, this may have been enough force to cause it to tear regardless, but in any case, the ligaments tore. Okay, so this is the CT compared to an MRI. And what do you see on this MRI here? Edema.
Probably some hemorrhage.
And it's probably kind of at that same segment. Yeah, exactly. I think the disc looks okay. There may be something, and not correlated with the CT, but then you see all of this edema, and you compare it here. How often would you see stir signal change in an acute ligament injury on an MRI?
That would probably be one of our best findings. Probably have local heads.
Yeah. And does that signal change persist over time, or does it become less obvious over time?
It becomes less obvious. So you're going to see initially it's going to be more avid and more intense, and then it'll dissipate over time.
Yeah.
Early onset is really helpful.
Yeah, so it's a little bit unusual to have an MRI right after an injury, but certainly a ligament injury would show up as bright signal change, especially on the stir image. It's a little bit more sensitive. Okay, so we know she has a ligament injury because of the stir sequence, and also because of this gap here. That the ligaments that hold those bones together are torn. Okay, this image is about 6 weeks after her injury. She went to rehab. She actually got a lot better, and I did not expect her to really wake up. She had a diffuse axonal injury, but she started to wake up and started to say, "My back is hurting me." What do you see on this CT scan that's different?
Disc herniation now, like change in this. Is the disc more like in the very front anterior?
Yeah, so the back part of this disc is gapped maybe a bit more than it was. There may be slightly more angulation. I think overall her alignment has been maintained for the most part, but not so much different than over there. But yeah, you can see a little bit, there's still that spot in the back part of the disc.
It would look like there's some type of soft tissue change there as well.
Are you talking about here?
No.
Or here?
Right there. Yeah.
Okay. What do you see here?
It looks like some type of soft tissue.
Just looking separate.
The calcification.
There's some distraction of the facet joint. We saw that. I didn't show it, but there's some of that here.
Yeah.
And so this is right after, and then this is 6 weeks later. And somebody mentioned calcification. She's developed a lot of calcification around that facet joint in 6 weeks in a 22-year-old. She's got a very arthritic facet joint. And so one thing that this case teaches us is that arthritis is one of the sequelae of ligament injury. And this is an unusual situation for it, but you can imagine that more types of degenerative chronic ligament injuries would also lead to arthritic changes, which is very important. Yeah.
So heterotophic ossification is very common after head injuries, severe head injuries, and I'm wondering how, you're calling that calcification, but I'm wondering how much of that is really hematoma that's turned into bone.
It's a good question, and it's possible that some of this is ossification of a hematoma. Yeah. That's a very good point. Yeah.
Is the facet joint just above that segment? Are we not seeing the connection in bone?
There's a little. They're opposed like they should be. Are you talking about here?
No, I'm talking just above that.
Oh, there's.
Right there.
Yeah, I think it's out of plane.
Yeah.
The
that's what I
pars.
wondered.
Yeah.
Can you point out where the segment underneath there, where the two bones should be on the facet? The facets, how they should be oriented compared to the one above it?
This one is how they should be oriented.
Right, underneath there's no contact.
Yeah.
Here, there's a distraction,
Right.
and then all this ossification of the. And you're right. It could be conversion of hematoma to bone. It could be just the ligament injury calcifying. Anyway, so we took her to surgery at this point and just fused these two levels. We didn't really need to do a decompression or anything, but I thought it illustrated some of the sequelae of ligament damage. Okay, here's another case. This is more of a degenerative condition. Patient in their 50s presenting with right leg pain and a little bit of lower back pain, but it's mostly the right leg. And I know there's some labeling here, but just look at the scan here and tell me some of the things that you see on this MRI. Yeah,
Just from
Robert?
the, non-radiological study.
We're all radiologists. Come
Yeah,
on,
I know.
man.
So as we like to see the cord signal, we want to see nice white all the way down, and every time we see a compression of that cord
Yeah.
signal, we're just
Yeah.
like, okay,
Yeah.
the neurology side would be like, oh yeah, that's a compression, and the
Yeah.
PT side's like, that's not good.
Yeah, yeah, and you would both be right. You
Yeah.
know, it's really quite insightful.
I try.
I do think that in the spine especially, my son had a ligament injury in his shoulder, and it was like, well, comparing one side to the other is really helpful. It's a little bit harder to do that when I was looking at his MRI. In the spine, we can compare one segment to another, and we compare one side to the other. And so you're saying that the signal here, I think you're saying that you can see something's different from this side to this side. And this is, the spinal cord is ended up usually around L1. So in the low back, we have that sac of nerves, and the spinal fluid is in that sac. So this is spinal fluid, and then these are the nerves on cross section. This side is the right side, this side's the left side. And there's this large, I'm calling it a synovial cyst, but you may not know that looking at the scan without it being labeled. But this is, we think, a synovial cyst. Yeah. Any other observations from this MRI? Alex?
The disc actually looks very healthy.
Yeah. The disc, we think about low back and degenerative disc problems, and this patient has almost no changes in their discs. So that's a really good observation. Eric?
There's facet changes, signal changes. There's also a lot of fatty on the outside.
Absolutely, yeah. Yeah, so in addition to having pretty healthy discs, we have a synovial cyst. We have, now I don't have comparison to another level, but I can tell you this facet joint's larger than it should be. And you can see where the synovium comes from. It's from this streak of signal change or fluid in the joint. And then here we have another arthritic joint, and then the cyst has come from that joint. And then another comment is that there's white here, and the same nerve that goes to the joint also goes to this muscle, and we sometimes see fatty infiltration of the muscle associated with this whole complex. So the whole back part of the spine is diseased and degenerated, whereas the discs are pretty healthy. And I think that that's one key point in this, is just not forgetting about the facet joints. Synovial cyst, also on the right side. Any differences that you see in this case? Yeah, so this patient has associated slip in the disc. Why do you think that occurred?
Possibly a pars, possibly an injury to the disc initially or to the facet joint.
Yeah. In this case, we don't really have prior imaging, but it could have been that this is a facet joint issue, and then the disc kind of gives way because the facet joint and the posterior ligaments aren't supporting the disc as well. I think that's one common scenario, is we'll start to see listhesis in facet joint problems. It could have been that the disc was an issue and it started to become unstable, and then in response the facet joints degenerated. I think they sort of influence each other as part of the same motion segment. Any other observations? Okay. Yeah, so this is just a synovial cyst with an associated listhesis. And in this case, we would most often elect to do a fusion. And then we had this case where they had a left-sided synovial cyst and maybe a very mild listhesis. And we did surgery, and after surgery, the left side looked great, and then the right side developed a synovial cyst. So we did the fusion at that point. So it's hard to know and predict exactly how these are going to go, but the point is that this is all diseased in the back, and oftentimes these patients require a little bit more than just the decompression.
Do you know how quickly that second cyst developed?
Within about 6 months. It was a little bit unusual. Not common necessarily for these to come back, and then it was an example of where it came back on the other side. Because I remember looking at the message about it, and I was like, oh, they came back, and then I was like, oh, it's on the other side, so it wasn't my fault. I'm just kidding. Okay. All right, so now let's look at this example. This patient actually has a tiny synovial cyst here, but we're going to look more at the L4-5 segment. What do you see at this segment?
A lot of stenosis.
A lot of stenosis. Very good.
It's very arthritic, really thick ligamentum plated.
Yeah, very good. Yep. So I'll point this out just so that you guys can see what we're talking about. So you can see stenosis in different views. The best way to look at stenosis in general, Dr. Jackson can correct me if I'm wrong, is to look at a cross-section of whatever you're looking for. So if you're looking at the spinal canal, the best way to look at stenosis is in cross-section of the canal. But you still can see it on the sagittal, and there's clearly sort of a bottleneck here at L4-5. This is where all the nerves live, and we saw in that previous image where I pointed out the little dots on cross-section in the spinal fluid. Very different with that situation compared to the severity of the stenosis here. And then this black right here represents the ligamentum flavum. So in response to the degenerative changes, the ligament thickens. Also, this joint is way bigger than it normally should be, and it's oriented a little bit more vertically than you would expect an L4-5 joint to be oriented. And we see this sometimes. And as a result, you've got bone spurring associated with ligaments really digging into the spinal canal. So spinal stenosis in the previous couple of cases was from synovial cyst formation. And in this case, this is a very classic example of spinal stenosis from arthritic change.
And you see that fatty infiltration.
Uh-huh.
Really
Yep.
dramatic there.
Yeah, this is a long-standing disease state of the segment. And it's associated, like you said, with the muscle and the fatty infiltration of the muscle. The ligaments are diseased. I'm sure that the sensory component of this is affected. And in response, the body's formed extra bone and extra ligament. And then that's created the spinal stenosis. So we treat this kind of stuff all the time. And again, the disc is a little bit degenerated. There's a little tiny bit of a slip there. But the main issue really is that all this back part of the spine is just arthritic and overgrown.
On the lateral, L5, S1 is there.
There's a little slip at L5S1. Uh-huh. Yep. Yeah, the X-ray, dynamic X-rays, standing X-rays demonstrate that there's some mild instability as well. Yeah.
In a situation like this, that the disc is pretty healthy,
Uh-huh.
if you do the fusion, what do you actually do? You do anything to the disc space?
Very good question. So sometimes in this situation, we'll do a laminectomy. And I really like We did this on a patient yesterday, a couple of them actually, a little minimally invasive laminectomy, small incision. We can go in, we come in from a side, a little bit off center, and we can, if you think about the corridor here, we can clean all of this out through a little incision. In this case, I'd probably do a fusion because of how diseased the facet joints are, and there's a slip. And when we do the fusion, we remove all of this, but we also take the disc out, and the disc space becomes our best fusion surface because this is a huge surface. We'll align the spine better with the screws, and then all the bone that's taken here, we put in the disc space. We actually file it down with a drill, and the bone is collected in a little basket, and then it's put into the disc space. And then we put the spacer and screws and everything. So that's a good question. So it depends a little bit on the severity of the stenosis. If there's neuroforaminal stenosis, because in order to alleviate that, you have to take the facet joint completely off. And if there's evidence of instability. And then if we do fuse, especially with like single level, I like to do the inner body fusion. Okay. So this, let's see. This case is, we're going to skip this one. Let's talk about this one here. Okay, this is cervical. So we've talked a lot about lumbar cases. We know we have facet joints in the cervical spine as well. Okay, and what do we see on this? And you can't see the facet joints on this scan because it's they're out of plane, right? So what do you see on this MRI of the cervical spine? What's that? Yeah, so there's the spinal cord's coming down. So this we are worried about the spinal cord. There's the spinal fluid around the cord, above and below. This segment here, there's some narrowing and compression of the spinal cord.
It's interesting that's on both sides too. You're having it from the posterior side with the facet joints, and the discs on the anterior side. So you're getting kind of like this.
Each segment's diseased and some arthritic changes on both sides of things, and we run into that sometimes because maybe you can approach this from one direction, but occasionally you have to go in to get the spinal cord completely freed up. I did notice on this that she's got 3 consecutive degenerated discs. And for the sake of time, what happens when a disc degenerates is the disc height's lost, which we know about, and we get bone on bone. But we also lose lordosis when a disc degenerates, and the body has to compensate for that in some way. So one of the patterns to be aware of is in the lumbar spine, thoracic, and cervical, if a disc degenerates, in this case it would tip her neck forward, or in the lumbar spine it would tip her whole torso forward. And in response to that, the body has to compensate by extending. And what happens with extension? We're loading our facet joints. And so at the level, at the C3-4 level, we're seeing primary facet problems. And this is if you look at scans, you'll see this over and over and over. Degenerated discs at the lower segments and arthritic facet changes above because they're compensating with extension. And it gets a little tricky in the cervical because the higher up we go, the harder surgical intervention is, especially coming in through the back. We really hope our pain doctors can solve these problems because it's very morbid to go in high cervical in the back and you can't access it very well from the front. And then over time, this is a previous MRI, degenerated discs, facet arthropathy develops, and then we start seeing listhesis. And this is just a common pattern. So maybe something to think about as you leave today is if there's any interventions that we can have with patients to prevent this. If we see a patient, for example, that has a degenerated disc, we could say, well, that's okay, and it is okay. Everybody has degenerated discs. But it's maybe even more important for them to take care of the situation to prevent some of the long-term sequelae, because it's a cascade of degenerative changes that occurs. And the facet joint is a very important part of that cascade. Okay, any other comments or questions? Great. Well, thanks for coming this morning. Appreciate everybody, and have a wonderful day.